Welcome to the Reinventing the White Coat podcast, where we delve into conversations aimed at helping you foster a healthy relationship with your career and yourself. If you're a physician feeling unfulfilled or burned out, or want to prevent yourself from going down that path, then this podcast is for you. I'm your host, Jennifer Scher, pediatrician, chief wellness officer, and executive and life coach. Sit back and relax as we explore ways to live your best life and have a career in medicine. Today, I welcome Dr. Adam Robison to the show. And Adam is a practicing internist and the chief hospitalist at St. Luke's Health Center in Idaho. But what really struck me about Adam is that he not only survived his hospital EHR upgrade, but he turned it into like a business opportunity for himself, which we'll hear all about. And, while most of us kind of, myself included, are pulling our hair out as we go through EHR upgrades, I was just so impressed to hear Adam's story and how he turned that into such a great opportunity. So Adam, first of all, thank you so much for joining us today.
Thank you so much for having me.
So why don't you start, as I always like to start, by hearing a little bit about you and your journey to medicine.
Yeah, I was your typical high school guy. I didn't have any ever have any idea of ever going into medicine. That was never a long-term dream. I was never a kid that wanted to be a doctor when I grew up. I barely graduated high school.
What?
And then I turned my life around, decided to go to college and had somebody help me get there. And then I really enjoyed science. I really enjoyed science and applying it, and looked at many different career opportunities using biology and my training there, but really found medicine interesting to me, the opportunity to treat patients and take care of people, and take scientific learning and knowledge and understanding physiology applied to people to help improve their lives. And so that really resonated in medicine. That's how I had decided to go and become a physician. And so that's how I got into the profession. I did my training at the University of Louisville for both medical school and residency. Came out of there as an internal medicine doctor and then started practicing as a hospitalist in the state of Idaho. My wife is from northern Utah, and so we looked for something regional, and that's why we landed in Idaho. And so that's kind of how I've been here for quite some time. But I really love taking care of patients. I love being a physician. One of my mentors in medical school, he was practicing physician until he was 94 years old.
Wow.
And he died a year later, and he couldn't do it because he just physically couldn't do it anymore. And so I wanted to be like him. I want to be like him to this day. I want to be practicing till I'm 95. I love being medicine. I love medicine. I love treating patients, love taking care of them. And so that drives a lot of what I do and how I approach problem solving to make this career a thing I can do till I'm 95.
That's great. So what's it like actually being a hospitalist these days?
It was interesting. You mentioned I'm the lead hospitalist for the health system I work for, and I foolishly taken that role over right as COVID was kicking off, and so that was an experience to try to figure out how to staff, keep my staffing up, try and deal with people being called out because I got the disease, and so trying to keep the staffing. So that was been a very interesting experience.
Yeah.
Hospitalists today, so that was that kind of, I think, for most of us hospitalists that practice during that was a very eye-opening experience for all of us. Before a lot of us perceived our jobs as really just being there to help augment specialists to do their jobs, to get the patients in and out of the hospital quickly from procedures and surgeries. I think that really put a different spotlight on the field of hospitalists as being critical to the hospital functioning in something like a pandemic, because that really fell on the shoulders of the critical care physicians as well as the hospitalists across the country. So I think that has been an interesting experience, and really, I think health systems themselves have really seen hospitals being a lot more important in a way we always were, but in really the function of the hospital, especially in light of the recent pandemic.
Adam, did Idaho get hit hard with COVID? What was your
Yeah.
experience?
Yeah, sure. The hospital I work in clinically right here, we have 10 hospitals in the health system, but the one I work in was the first hospital. We have, I believe, what we were told at the time was we had the first hospitalized case of COVID in the whole state of Idaho. It was in the hospital I work at in the middle of nowhere in a town called Twin Falls, Idaho. So that was an interesting experience. Yes, we did get quiet. We got hit hard, just like I think everybody did. Had lots of people on the ventilator, coming in and seeing who died the night before. And so, yeah, just that was a very interesting experience. Something I hope I never have to go through ever again in my career.
Sure.
Yeah, we got hit hard just like everybody else did.
Yeah, yeah. But is there a divide, do you feel, between the hospitalists, physicians, and the outpatient primary care physicians? What's that relationship like?
We have so in the town I work at, it's because it's a relatively small town. We have a pretty good back and forth. But I think one of the things that has happened with the advent of hospital medicine and hospital-based primary care, essentially internal medicine doctors just based in the hospital, there is a little bit of divide between outpatient and inpatient. And so there often tends to be a little bit of a disconnect. You have to go out of your way to facilitate those relationships, which we have, because they are critical to actually providing better care, because that handoff, every time you have a handoff from one provider group to another provider group, breakdowns occur in patient care. And it's that episodic care is bad for patient care. And so, but with how sick patients are becoming these days, way more complex disease, people are living longer. You really do need a dedicated physician group that's just in the hospital, because it becomes too taxing on primary care docs. Have to be in both worlds. It's just too much.
I agree completely. But that handoff is an area that needs improvement for sure in the
Yeah,
system. And the
I
respect
think.
of one another too.
Yeah, and I think that's where that's the us versus them mentality that always happens when two parties don't commingle. You end
Yes.
up having these false narratives about by either party that kind of percolate. And you have to, and the way to compensate for that is really through better communication through the different provider groups, have to talk to each other. That's the only way that situation gets improved. There's no other way of doing it.
Right. Okay. So bring us to when was it that you guys went through your EHR
Yeah.
upgrade?
So we in 2016, I'd just come out of residency. I had a little bit of experience moonlighting in a urgent care that had used Epic for a couple years.
Mhm.
And so I had some experience with Epic, but very little. And then then when I started here, we were doing kind of a mixture of like dictated dictated charts, paper charts, computer physician or CPOE ordering system, kind of a mixture of that. And right as when I started here in August, and then a couple months later, we transitioned into the Epic. So I was here kind of in that tail end transition of those two different systems.
Okay. And what was your experience? You were a youngin, so you probably managed it
Yeah,
better
well, it
than
was
some of
fun.
the
I kind
others.
of I had given an Idaho chapter of the ACP a few months ago. I spoke at that about kind of my experience of technology and medicine, and it was interesting where I trained at. We trained paper charts. So when I first started training, I used to write everything. Just we would provide we would pre-round with the patients in the morning, write our note, give them to the attending. So I'd grown up in the era of handwriting notes. And so I've kind of gone through this whole EHR transition kind of it's been following and paralleling my journey in education and as attending. But when we went live with Epic, I think I saw it really affecting different provider groups. Younger physicians like myself were earlier in my career. It wasn't as hard a transition, but I had older colleagues that were in my group that had been practicing for 25, 30 years, and they're like, I'm done. And it really caused a couple of them to actually leave, or they struggled quite a bit, and they eventually just had to quit the field, which made me think a lot of that, like, back to my initial story of Dr. Stuart Urbach, who was a physician mentor of mine. And think of these physicians that have a wealth of knowledge. They've been practicing for so long, and they have so much to teach us younger physicians. Yes, we're closer to the academic and probably most up-to-date guidelines, but they've seen so many more patients. They've seen so many more different presentations of diseases than I had at that point. And so these types of tools, EHRs, can be helpful, but I also fear the way they sometimes have a tendency to drive some of these older physicians out of the field of medicine, and that kind of brain drain that happens to the practice is, I think, somewhat detrimental for younger physicians like me who need that kind of help. And I would often ask them questions, hey, I've never seen this before. What do you think of this? And losing that, I think, is definitely a side effect that we don't talk about in the field of medicine from the advent of EHRs.
Yeah, I love that point. And we live in a society where old people are sort of marginalized, but the experience, I mean, I remember training with people who that bedside learning, you don't need an echo. You can actually hear what's going on in the heart and diagnose a heart murmur with the stethoscope and
Right.
it's just so beautiful. We're
Absolutely.
losing that.
We are, and I think, yeah, and I think as the EHRs as they are currently built, they're not meant to augment a physician's ability to see patients and make us faster, right? That's what you would think. Most technology in any sort of sector, when we implement technology, you can think of banking, you can think of all different areas we've had technology come in there. It usually ends up augmenting the person's ability to do whatever job they're doing or make life a little bit easier. You think about the idea of banking, online banking, how quick and easy that is, and how we all take for granted, and how it's so obviously that's what we should have, right? You can never imagine going back to the day where you just have to always use checks, have
Mhm.
to go to the teller to get the money out. And this is such a seamless, easy transaction, which has facilitated so much more other industries because of that, right? In medicine, for some reason, we haven't really embraced that ethos or philosophy around technology. The technological system that we often implement within health systems are really force the physician to bend themselves in a way to um, accommodate the system as opposed to system accommodating the physicians and augmenting us. And so that's where I think for me, um, how as I think about technology in the healthcare space, and it's that really fundamental philosophy we need to be thinking about. Any tool that comes into our practice really should be there to make my job easier and
Right.
offload some of that cognitive burden that isn't really is getting away of my ability to care for patients, not adding to my ability to care for patients.
Yeah, and to add to that, the banking metaphor that you use, it also makes me think about how easy it is to, as long as I have an ATM card, I can bank anywhere, right? It
Yeah.
speaks to the universality, and we've really chopped that up horribly in
Oh yeah.
healthcare.
Well, yeah, you think about I use that analogy because it's a very apt analogy. We think about financial data being so important to keep it secure, right? We talk
Right.
about how if we figured that out with financial data, I mean, I think about my own retirement portfolios and all sort of stuff. I manage it all online and it's very seamless and easy.
Yeah.
And it's very secure. I mean, for the most part, we trust it because it is secure. And but for some reason in the healthcare space, we're so scared of patient data. We like, oh, we have to do this really wonky system, which isn't secure. We have a very apt other system that we use all the time that has very secure ways of managing data that we should be really replicating, not shying away from.
Yeah. But so, I wonder what about you it is that so, you're going through the upgrade and you're learning Epic and you're seeing a ton of patients and you said that some of the doctors are retiring and
Mhm.
it's so stressful. How did you sort of show up as your like best self in order to face this challenge and then tell me, what you did and about
Yeah.
this.
I remember that I still remember where I was sitting when I had this idea of the company. I remember sitting in front of the electronic health record. We'd been alive for a couple of years going, and I was remember having to take data out of this system and put into another website to do this process, medical calculator for me. Like, I need to figure out a MEL score. And I was like, oh, because like you can't do that in your head. That's something you have to put into because it has logarithms involved and you can't do it on top of your head. And I'm like, this is so stupid. Why am I doing? Why can't I just do it with an Epic? It should just do it for me. Like this isn't like there's so many other software programs that do that kind of stuff. It would seem so obvious. And I'm like, why isn't this built? And then I'm like, this should be something we could do. We can do this. This is easy. This is just math. We can do it. And patient cirrhosis software system should know patient cirrhosis. I should know, MEL score. This should be done for me automatically. And that's kind of what that was this idea of like, oh, we should be able to build a tool within the software. And that initially I started like let's talking to my IT people and say, hey, can I fix this problem? Like, can we just do it in Epic? Can we build that? And it really became obvious that in order to build it within an EHR itself natively, that type of logic where the software would look for what medical calculators that need to apply to the patient and do it for you automatically, that type of logic is very difficult to build within the current EHRs. Because again, EHRs are not made for that. They're made for billing. They're
Mm-hmm.
made to capture billing and submit charges. That's what they're fundamentally for. And they really aren't, they're starting to get some of these other functions, but they really haven't embraced it wholeheartedly. And so that was the idea. Going back to what drove me into medicine in the first place was I love problems and fixing them. Like I love the idea of like, okay, let's figure out what's wrong with this. Let's break down the fundamental issue here, what's wrong, and then see what are the pieces that need to be fixed so we can fix the system as a whole. And that's has been kind of how I viewed everything. And it's kind of that's what drove me to medicine in the first place. I can take that kind of same philosophy and apply that to patients. That same type of philosophy and how I view problems very much was the same type of thing here that drove me. I'm like, oh, I can fix this problem. I just got to figure out what are the pieces that are broken here and figure it out, or find the right people around me that know how to fix that problem. And so that's what I did. And that's what we've been working on. And it's been great.
Yeah. How do your colleagues respond to you or react to you?
I think initially they thought I was crazy. And then they started seeing me actually accomplishing it. And then they saw, oh, he can do this. What I've often realized is when you do something radical, it's way outside the box, you are going to have the people that tell you it's usually one of two things. Oh, that's nice. Have fun with that. Good job. I wish you all the best. Or that's never going to work. You're never going to find a person saying, hey, you're right. That's a fantastic idea. Let me work with you to get that. You're very rarely going to find that person with you. And so you have to go, okay, you have to really appreciate the problem inherently. Do I understand the problem inherent? Do I understand the really fundamental drivers of that problem? And I understand it? And they have to just go and fix it. If you're waiting for that external validation, like, oh, you're on the right track, you often are going to be, you're never going to get it. So you can't, it doesn't exist. Especially when you're doing something very radical outside the box, like how can I fix this problem? And it seems very instrumental to most people. It really takes that kind of viewpoint of how you fix problems and go, okay, this is a fundamental problem. And it has to be tied to a bigger idea of like, oh, if I can do this, I can provide better patient care. If I can fix this problem, this will help me be a better doctor. That's what drove me as well to fix that, because it was tied to this more fundamental purpose of why I do what I do. And back to that original idea of practicing till I'm 95.
95.
I know people think so back to my point, everything thinks I'm crazy when I say stuff like that. Because I really love what I do. I love taking care of the patients in my community. I love helping them out. I just love it. But I know if I don't fix the system, it's going to burn me out. And I've got to figure out a way to fix it for myself, because nobody else will fix it for us.
Yeah, yeah. So I recently was doing a survey, getting some feedback from some doctors at our practice about what are, their greatest challenges. And one of the obvious themes that came out were EHR related. And there's a huge range of comfort with it and experience with it. So our EHR rollout went and everybody got their training, but different people take different amounts of knowledge out of it and then have different comfort levels. What's your role as you're being the chief? Like, how are you helping those ones with the less strong ability to function?
Yeah, I think that's where I think it's really, unfortunately, I would say a couple things. That my first response is, unfortunately, this inherent to the EHR itself is a fundamental flaw that you should require training for this. You think about all the software we use in our regular day-to-day life. We don't require 3 or 4 days of training on how to use an EHR and still not really understand how to use the system, right? That's because the systems themselves.
Oh my God, blowing my mind.
Yeah. I mean, like you think about you set up, you think about how complicated a home network is, right? You think about setting up your Wi-Fi at home. That's actually a relatively complicated thing. But the people that make these devices figured out a way like, hey, that, you plug in the wall and you put in the thing, everything else runs. I mean, you think about all the stuff that has to happen for that to work. We take for granted because it has become so ingrained in us. Those interfaces are very complicated. The firewalls, talking to and doing all that sort of stuff. For some reason, we haven't taken that philosophy into EHR because it really shouldn't require that. You think about what you're actually doing with an EHR is really simple, right? You're putting orders in, you're writing a note, and you're dropping a charge. There's really not much else, and you're reviewing some information. But for some reason, we've made these cockamamie systems that are so complex. I don't care what EHR you're using; they're all the same. Because I've used 5 or 6 of them. Back to the idea, how do you help people with that? You can't, so either you can take an approach like I can, which is I'm trying to work on actually fixing the system. So we're building these systems. I use in my practice and we're rolling out other health systems. But more fundamental to that, I think you go, what are the pain points that a provider is experiencing? So like, let's say you have a provider, a valuable provider, 65, they still want to practice, but they're having hard. I think figuring out, you got to augment that, because I think that's like his point. I think we think, oh, they just can't figure it out. They're just being old and whatever. They need to get with the times. But that philosophy is so dangerous, because you're losing so much knowledge when you go, you know, Dr. Smith, he's just old, he doesn't get it.
Right.
I think it's you're losing that. So I think the issue is, how do we make systems in place that can help augment these providers? Because man, I tell you, the reason why those people practice for 30, 40 years is because in those relations they deal with those patients that is such an important relationship to maintain. Because I tell you, when those people retire and those patients are left without that relationship, they have to get that relationship. It takes years for that to be developed.
Right.
And you really don't gain that therapeutic relation with the patient first a few years. You have to have that, and especially in the outpatient setting. I mean, that's where, and in the years to come, outpatient primary care, that's where you're going to have any of your savings in medicine. And if we're going to drive any sort of improvement in our population health, it's by having a robust primary care clinic practice. And so I think we have to, as leaders, have to help identify those people and really don't look at them as a problem. Look at them as that our system is failing them. How do we make the system better for them? Because if we don't figure that out, all of that work they did to develop this relation with patients and develop that, we're going to lose. And it's going to take a long time to regain that and build that up again. And I think it's really underappreciated how much we lose when those providers retire prematurely, because they just gave up with the stupid system they've been handed.
Yeah. And I think a lot are, for sure. How many years, Adam? Make a prediction. How long before you think that this vision of yours, where charting and
Yeah, so
AI and all of that can support us in a way?
I'll put it this way, we're well on our way. We already have a lot of stuff in place that we're in the process of rapidly developing. I've got a great team behind me that does it. I think this is going to be, there's already a big movement in opening up the EHRs, opening up data, interoperability. This stuff, as it gets opened up, the EHRs will have to they're going to have to open up once those EHRs stop keeping their data so closely and not letting it out and not letting data models out there. This is going to open up. It has to. I think about 5 years. I think it's going to change rapidly in the next 5 years, because I'm already seeing stuff. And true, I'm kind of at the front end of this stuff, because all the stuff we're doing, we're ahead of the curve. But in Europe, there's a thing called Open EHR, and it's a really interesting and it's fundamentally changing how people interact with healthcare data. And it is a movement that outside the U.S. is gaining a lot of traction. Actually, on our board, one of our advisors is actually the CEO of Open EHR. But they're looking at, and they're going to have, the EHRs will have to change, because the market's going to demand it. And there's going to be something that comes with a better solution, a better mousetrap here, that's going to fundamentally change how we think about it. I think the EHR is going to fundamentally change in the next 5 years. Like, it'll be a completely different experience.
So to those people currently in med school, they will have a completely different experience.
If me or other companies like me are successful, I think in 5 years, I think there is going to be, because one thing that I didn't talk too much about, the 21st Century Cures Act, I think was really underappreciated how revolutionary it was, because it mandated certain interoperability standards that every EHR vendor had been pushing off for years. And that has opened up the data in the EHR to a way that wasn't possible before then. And so now people like me, companies like me, that have different ideas like how we can work with data there is happening. And now we have the ability to do that, because we can actually get data of the EHR before the EHR systems were holding so tightly. That allows companies like me to innovate and develop some better tools that can help augment these physicians, as opposed to a glorified billing system, which it is now.
Yeah, that speaks to what I was wondering. How much of this did you think was political obstacles versus corporate obstacles versus, what other things?
Actually, it's one of those things where I think the federal government got right. If you actually look at the 21st Century Cures Act, I think they got it right. I mean, I think all of us probably loathe the High Tech Act, which made EHRs mandated, essentially, that we all kind of had to deal with. And the follow-up to the High Tech Act, which was the thing that made EHRs mandated, was the Cures Act. And this was fought by vendors for a long time, but it's finally making it that it has to be. And I think this is going to really change things. We're already starting to see people look at this, but it's still relatively new. People don't really understand SMART on FHIR and some of these interoperability standards. But when people start understanding these companies like mine and other out there, this is going to change a lot of stuff, because all of a sudden, a lot of these things that people thought EHRs could do, now we'll be able to do through third-party add-ons and other EHR solutions.
So you're giving me optimism.
Don't give up. Yeah, don't give up hope yet.
Which is really an amazing thing. I'm an eternal optimist, but when it comes to technology, it's one of my areas that's less optimistic than others. So I'm excited to be talking to you. Now,
I
I
have all
know
sorts of visions for it,
that
but
your company, AI Medica,
Mhm.
it's not something that an individual can take advantage of, but tell us a little bit about it, and who it could serve, and anyone who
Yeah,
might be
so
interested.
it's the focus right now of the tool is very limited. We're focusing on integrating disease models to help improve quality outcomes. So you think about your, whatever that may be. I'll use a MEL score, but we can look at a Caprini score for DVT prophylaxis. Automating these scoring systems that people do, they actually will save a lot of money and have better outcomes to health systems. The tool itself, right, but we are rapidly moving into computer assisted coding, so we can actually suggest a bunch of codes so you can optimize your coding. So instead of giving all CDI queries for the hospital or the outpatient, we can give you an optimized list of codes based off pulling data out of the EHR, figure out what codes may apply to this patient based on parameters. And then we're looking at we're actually rolling out a tool that's going to automate level of service billing. So we recently had the big changes in CMS rules for level of service for and nobody understands the rules, right? All of a sudden, right now, it probably takes 3-4 years to figure it out. We've actually have a solution where we'll automate what level of service just based on the rules, and we can ask a few questions and do that for you. Those are the solutions we're at right now. There's several other in the pipeline that are coming out as well. Back to your question, how do you interact with this? It is really meant for practice or hospital based. So if you have a health system or a small group practice, that's any of those types of things, it's really meant to automate that. And so basically, at its core, it's an automated chart review tool. So instead of looking around for clicking all 3 different tabs for all data, we actually can just surface data on clinical context. So whatever the clinical context of the patient, we can present the relevant data to you on the chart and give you context that data.
So I almost pictured like a Google search bar on top of my.
It's even easier than that. It actually is a button click, and it literally goes, "Oh, you're treating a patient with cirrhosis. Oh, you want all this stuff. Or your patient's got pneumonia. Oh, by the way, do you meet the sepsis criteria? And oh, here's your coding profile." That's what it does.
That's pretty fabulous.
Yeah, I could use I'm the beta tester, so I get to use it in my practice all the time. So it's great. I get to build the tool and then I use it, and it's been fantastic. So I'm a little biased, but I do love it.
All right, Adam. I was going to ask you where are you optimistic, but it sounds like in lots of places.
Yeah, it's just been fun. I mean, I've been doing it for 5 years now, and one of my guys that helped me out initially get this thing started, get the MVP built, he always said it's always, you have a good idea when doors keep opening. And so the fact that we're here 5 years later from the idea tells me I have every reason to be optimistic. So, it's been great. It's been a lot of fun so far.
All right. And I'll say, as we sort of wind down towards the end, what advice would you have to share with people?
Yeah, I told some of this, and I don't know if it's good advice or even revolutionary, but when you're presented with a problem in front of yourself, you have either two options. You either go, "I'm quitting, I'm going to do something else," or you stay part of the system, you try to figure a way to work it out. The latter is more difficult, but man, it's way more rewarding if you can figure it out. And a lot of people just go, "You know what, it's too hard, I don't want to deal with it." And sometimes that's appropriate for the problem, and sometimes you can't fix it within the system. But often, if you have the put spot to stay around, and it becomes a much more rewarding experience, and even though it can be frustrating at times, but when you figure it out and fix the problem, it becomes really, really rewarding.
Yeah, that's great advice. All right. So I would just add one comment to that, which, I was actually at the physical therapist this morning for myself, and I have a rotator cuff injury. And as I was doing like an exercise, the pain that I was having, I couldn't tell if I was like having good pain or bad pain. Right? You want to do the thing that's going to help improve and not, right? And so
Right.
I think about this sort of in the sense of like, am I the one who needs to quit, or am I the one who wants to push through? It's a similar thing. Like, is the level of stress beyond, or is this something I should work
Right.
on and push
Is it
through?
causing me harm, or is it actually good?
Right. Where am I
Yeah.
going? This is
Yeah.
good. But Adam, I hope and pray that your company is hugely successful and that your predictions for 5 years from now are right on point.
Me too.
Thank you so much for joining us today.
Thank you so much.
Okay, and as I send us off, I always give a great big thank you to all of our listeners for choosing to spend your precious time with us, and hope to see everyone again on our next episode of Reinventing the White Coat. For this episode of Reinventing the White Coat, if you enjoyed this conversation, subscribe now so you don't miss an episode. If you're interested in coaching or in being a guest on the podcast, you can reach out to me online at sharecoaching.com. Thanks for listening, and don't be afraid to live your best life.